Okay, well, Dr. Woods is pulling up his presentation. We'll just get ready to get started. I wanted to thank everybody for joining us today. I hope everybody's continuing to stay safe out there. We normally do these lectures in person. However, obviously under the circumstances, we've been doing a lot of virtual lectures, and they've actually been working out pretty well. So I hope you find the information pretty informative today. I will be recording the lecture, so I'll be sending the link out to everybody tomorrow in case you need to revisit it, or if you'd like to forward the information along to anybody that may benefit as well. Again, our lecture today will be given by Dr. Barrett Woods. Dr. Woods is one of our spinal surgeons here at Rothman Orthopedics. He practices out of our Egg Harbor Township and our Washington Township location. His topic he will be speaking on today is management of common cervical and lumbar spine problems. So Dr. Woods will be giving his lecture, and then we will have some time after for question and answers. There is a chat section at the bottom of the screen. So if everybody can just type your questions in the chat section, Dr. Woods will get to the questions at the end, or you can unmute yourself if you prefer and ask the question out loud. I am going to keep everybody on mute throughout the presentation just to avoid interruption.
Okay, here we go. Another Ring Central meeting. I've never done so many Ring Central meetings in my life as over these last couple months. You know, so it's kind of an unprecedented time. But it's still nice to be able to talk and kind of share ideas and discuss common issues that certainly I see on a daily basis. As Jen said, I'm a spinal surgeon. Just a little bit of a brief background on myself. I'm from Pittsburgh originally. I went to college in South Carolina at Clemson and then medical school and residency at University of Pittsburgh. I did a spinal surgery fellowship at Thomas Jefferson, and I am now a practicing adult spinal surgeon. And I take care of the full gamut of spinal pathology in adults, from scoliosis to tumors, trauma, and I see a lot of trauma, you know, motor vehicle accidents, diving injuries, and also degenerative conditions. And I practice predominantly in the South Jersey area. Occasionally I will go to Philadelphia. So, you know, as a spine surgeon, it's kind of fascinating. It's very humbling in that, you know, you see people come all the time who are terrified. You know, there's such negative associations with spinal surgery for a lot of people. They have uncles or aunts or somebody who had an operation that didn't do well. And so you see a lot of fear in people's faces when they come in. And it is very humbling and gratifying when they come in after surgery to see them have improved. And the vast majority of people do improve. And that's really predicated upon doing surgery on people who actually need it. And so in order to understand that, we're going to kind of go through some spinal pathology, common cervical, lumbar pathology that we see in patients who are actually indicated to have surgery and the ones who predictably have good outcomes. When talking about cervical or lumbar pathology, a lot of it really starts with the intervertebral disc, which is the cushion between the bones. It's comprised of an outer annulus fibrosis, which is kind of like a tire, and the inner gelatinous portion, which sucks in water and serves as the shock absorbing capability between the bones. And as we age, this degenerates. And we have done a lot of studies and research to try to determine how we can augment or slow that course of degeneration through biological treatments such as gene therapy and different targets to prevent that disc decline. However, unfortunately, to this point, we have not devised a way to do so. But as that disc degenerates, it can herniate, it can result in compression of nerves or spinal cords, it can lead to the development of arthritis. So the intervertebral disc is a big problem, and that's really typically the nidus of issues that we see that commonly involve both the cervical and the lumbar spine. And this is just kind of an example of disc degeneration. So you can see to the left, healthy disc. The disc have maintained disc height and good turgor. And as the disc starts to dry out, which is the center portion, that disc becomes dry and desiccated. It loses its hydration. And as a result, it begins to collapse. And you can see to the right, the end stage disc degeneration, which the disc is collapsed, the bones are deformed because they're bumping together. That can ultimately result in compression of nerves, and that's typically something that's treated with surgery. And the analogy is a tire. So you can kind of see that outer tire kind of wearing down, and this is the result of wear and tear of life. And this is just another kind of healthy section showing a normal disc. You can see that bright center portion, that's called the nucleus, that sucks in water. And on the right, you can see as that disc degenerates, it becomes fibrotic. And again, this is normal aging. There are certain things such as smoking and obesity which exacerbate this problem. But unfortunately for us all, this happens to us to varying degrees. If it results in compression of nerves or your spinal cord, then typically surgical intervention is warranted. In regards to the lumbar spine, this is an MRI. MRI shows nerves, ligaments, and soft tissues. The nerves in the back supply the legs. And so patients often complain of back pain and come in with back pain. Back pain in and of itself is not something we typically treat with surgery. Back pain is typically muscular. What surgery is designed to do is remove pressure from nerves. So patients who have a difficult time ambulating or walking because of pain shooting down their legs, that's typically secondary to stenosis or compression of the nerves in their back. And sometimes patients don't believe you. You know, my own mother had pain shooting down her leg, and I was telling her it was coming from her back, and she said no, she thinks it's her knee, and it was referred pain from her back. And so, you know, people often have a misconception that, you know, back pain is something which is treated with surgery, but typically it is not. It is if there is nerve compression, which is affecting someone's function, then operations are designed to remove pressure from nerves. So this is a normal MRI cross-section and sagittal, which are showing no stenosis. You can see the spinal canal is wide open, the white lubricating fluid, and MRI is obviously a test that we commonly get to assess for nerve compression. The cauda equina is the confluence of nerves in the lumbar spine. Again, each nerve in the back supplies a specific portion of someone's leg. And so when someone comes in to see me and they're having leg pain or ambulatory dysfunction, it's really about putting a puzzle together. And when I see these patients, I'm already thinking in my mind, where potentially could their nerve compression be in order for them to have these symptoms, because there's reproducible patterns of pain. And people who have nerve compression, we take for surgical intervention to remove pressure from nerves. This is just an intraoperative photo showing a laminectomy. So laminectomy, this is the thecal sac here. That sac contains or holds the nerve, so we remove pressure from that, and that is very effective at improving patients' leg pain and ability to walk. This is just kind of the dermatomal map. So someone comes in with pain in their legs or their arms, there are reproducible patterns of pain. The nerves supply specific portions of people's legs. So someone that comes in with a pinched nerve in their neck or in their leg, typically we already have thought about potentially where that problem would be even before seeing an MRI. And the people who actually undergo surgery are people who have pain or weakness in the distribution of the nerve, which is predictable, and then they have imaging studies which support that. I have a lot of patients who may come in that may have evidence of nerve compression, but they don't have symptoms of nerve compression, meaning they don't have pain, numbness, or weakness in their arms or legs in the distribution of that nerve. Those are not people treated with surgery. So just because you have nerve compression does not necessarily mean you need an operation. But if there is a correlation between how you feel, pain in your legs or weakness, and what you have on imaging studies, nerve compression, then those are the circumstances in which we consider surgery to improve those symptoms. So indications for surgery. Why would I do an operation on anybody? There's really three tenets for undergoing an operation on your neck or on your back. One is for neurologic compression of nerves of the spinal cord. Instability of the spinal column. If it is shifting abnormally, it places those nerves at risk. Or if there's a major deformity in which they have a scoliotic curve. And we can kind of briefly go through these things and how they're assessed. So this is an MRI of a young man that I took care of not too long ago. He came in with severe pain in his legs. He could not walk. He was lifting, squatting weights, and he heard a pop in his back, and this was his MRI. And if you look towards the bottom of the MRI, you'll see this big black mass within his spinal column, and that is a large extruded disc herniation. So he blew out that annulus, that ring. The disc material has protruded into his spinal canal. As a result, he had severe pain and weakness in his legs, and he underwent surgical intervention. So this is an example of neural compression, nerve compression, and symptoms that resulted in surgery. This is another example of a disc herniation. So a disc herniation at the L5, S1 level typically will compress the S1 nerve root. That will cause pain in the butt, back of the thigh, and the calf. And so you can see this MRI on the left. These are pretty healthy looking discs at every level except L5, S1. And then at the very bottom level, that disc is degenerated and there's a protrusion or disc herniation here. Now, when these patients initially come in, we gauge the severity of their pain and also gauge for weakness. In the absence of weakness, in the S1 distribution, that would be calf. If the person couldn't stand on their toes, if they have weakness, they undergo surgery. If they don't have substantial weakness, injections and physical therapy are the main line or frontline treatment for this, which is effective typically about 60 to 70% of the time. If the symptoms persist and they have severe leg pain in the distribution of the nerve compressed or weakness, then that's when we can do a decompression procedure to remove the portion of the disc which is pinching the nerve. And that is very effective at improving leg pain. So this is another example of a disc herniation, something that we commonly see. That outer ring has been cracked. The inner jelly material is inside the spinal canal and pinching the nerve on the right side. This person had severe right leg pain. And so a minimally invasive microdiscectomy is about a 45-minute operation. Patients go to home the same day, and typically they wake up with improvement of the pain that they were experiencing in their leg. Cauda equina syndrome is something which is a more serious situation. Cauda equina syndrome occurs when there is a massive herniation or severe compression of the nerves in the back. This will present with numbness in the groin. Patients can be incontinent. They can have severe pain in the legs. But the biggest concern is their bowel and bladder function. So if you have somebody that starts to develop issues with bowel, bladder function, incontinence, numbness in their groin, if they do have a large herniation like this person had, then they emergently undergo surgery. And really the purpose is to try to regain function, get the pressure off the nerves so the nerves can breathe to hopefully prevent permanent damage. If you wait too long in these circumstances, then the damage can be permanent and irreversible. So it's important for these people to be treated in an expedited fashion. Just another example of disc herniations in the lumbar spine. So this person was a construction worker. He had 2 herniations. The circle shows a bulge. People commonly ask, what's the difference between a bulge and extruded herniation? Remember that disc is a ring. So a bulge would imply the ring was still intact, but the wall was just kind of blown out or stretched, and it was impeding on the spinal canal. An extrusion is when that inner jelly material is squirted out and is actually inside the spinal canal itself. And so he had a bulge on the bottom, which is the circle. The area that red arrow is actually pointing to an extruded herniation, in which the disc material, the nucleus pulposus, was extruded into the spinal canal, and he was having a lot of pain in his legs. And so that red fragment illustrates that extruded component. If you look at it on cross section, that green circle represents the thecal sac, and then those 2 little green dots on either side are the nerve roots which are exiting the spinal column. And then that red fragment is the disc herniation, which is pinching the nerve. So this is the person's left side, severe pain in the left leg, which correlates with that nerve. This is a pretty straightforward microdiscectomy operation. Patients are very happy, pretty quick improvement in their symptoms and recovery. They love it. This is another example of a kind of a disc herniation. So this on the left is illustrating a normal MRI, a normal cross section. So we're looking at someone from the top down. The front is the bone, the vertebral body. The back is the lamina and their paraspinal muscles. And you can see that circle is the thecal sac. Little dots are the nerve roots, and these squares represent the nerves exiting at that level. And here on the right, you can see that disc herniation. So that red circle is the herniation. It is impeding on the spinal canal. It is narrowing the spinal canal. That is resulting in spinal stenosis. Stenosis will cause pain in the legs and difficulty with ambulation. And this is something that we commonly treat with surgery to remove that pressure. Again, it's very effective at improving someone's leg pain. And this is just another example of that, of a severe disc herniation. So if you look on the right, This is a normal cross section. That spinal canal is wide open. We go down to L5S1, the canal is completely occluded. There's a huge herniation. This person presented with severe gait dysfunction, pain in their legs, weakness, and underwent surgery to remove that pressure. So lumbar disc herniations are very common. They are not always treated with surgery. Back pain in and of itself, typically we treat with physical therapy. If someone has a large herniation that is resulting in compression of a nerve and they have pain or weakness in that distribution down their leg, then an operation is an excellent tool to improve people. And it's something that we commonly do. It can be done in a minimally invasive fashion. This is kind of an intraoperative x-ray showing the size of the incision. And that material to the right is actually the disc material that has to be removed from the spinal canal to remove pressure from the nerves. So spinal stenosis is kind of a generalized term. I often hear my patients say they think they have stenosis when in actuality they don't. But essentially what stenosis, it means it's a radiographic diagnosis. It means that the space for the nerves is limited. And that space can be limited from arthritis, from bone spurs. It can be limited from disc herniations. It can be limited from translation from the vertebrae. But stenosis in itself is a radiographic diagnosis. The symptoms of stenosis are what we treat. So if someone has stenosis in their lumbar spine, but are not having symptoms in their legs, difficulty walking, then these people are just watched over time. However, if they're having difficulty walking, pain shooting down the legs, weakness, then we consider doing operations to remove pressure from nerves. And surgery, again, is very effective at improving people's ability to walk and in treating leg pain. And so this is just an example of the things that can cause stenosis. So not only disc herniations, you have a bulging disc that can narrow the spinal canal. You can develop bone spurs from the facet joints. The facet joints are the joints which allow us to rotate, and as those joints become larger and arthritic, they can impede on the spinal canal and cause stenosis. And there can also be thickening of the ligaments in the back, which can also narrow the spinal canal. So there are multiple things that can contribute to stenosis. The ultimate result of stenosis is compression of nerves. Compression of nerves can affect your ability to walk and cause pain in your legs. And the classic, people classically who have spinal stenosis walk with this shopping cart sign. So, they can walk, if they're leaned forward or bending forward, it improves their pain. And the reason for that is when you lean forward, it opens up your spinal canal. So leaning forward will actually give those nerves a little bit more space to breathe. And that's why you see people walking with that forward flex posture. That's typically indicative of spinal stenosis. And that's their body's natural compensation for opening up the spinal canal and allowing those nerves to breathe a little bit better. And so this is just an example of stenosis. And people that have significant stenosis often will have kind of this triangle type sign. So a normal spinal canal should look like a circle, and that's what you see to the right. And if you look to the left, that is pretty classic stenosis, and that triangle shape occurs because those joints in the back, the facet joints, become arthritic, and they impede or encroach upon the spinal column, cause nerve compression. That causes pain in the legs and difficulty with ambulation. And this is just kind of another example of these joints here, these facet joints becoming arthritic and narrowing this spinal column. Instead of this being a nice big open circle, it looks like a triangle. And that's pretty classic spinal stenosis. And stenosis can get severe, and it can get to the point where it can substantially affect your function. And very commonly, I see people that have, tried to push on throughout the years, and by the time they come to see me, they're at a point where they're having a hard time walking at all. And that's because their stenosis has slowly worsened over time. So this is an example of very severe spinal stenosis on the right, where the thecal sac, which holds the nerves, is gone. You can't even really see it. So you can imagine the amount of pressure that is exerted on those nerves. And so people with stenosis of this magnitude typically need surgery if they have any hope for improving their symptoms. So another indication for surgery, one is nerve compression. If you have nerve compression and pain or weakness in the distribution of the nerve, surgery is something we consider. If there's instability of the spinal column, that is also a reason that we would consider an operation. So this CT scan is illustrating someone who has a slippage of their vertebrae. The bone is translated out of position at the L4-5 level. That results in compression of nerves, back pain, and leg pain, and surgery is very effective at treating that problem. And so if you look this X-ray on the right and the MRI on the left, excuse me, the MRI is on the right, the X-ray is on the left, the white is the lubricating fluid. And if you look down here, you can see how dark it gets. That represents those nerves being clumped together or pinched. And the reason that's happening is because that bone has shifted or translated out of position. And so in these circumstances, we can do a laminectomy, remove pressure from nerves, and a fusion to stabilize those bones so they do not translate anymore. It's very effective at treating leg pain. Very commonly, people are, I tell them they need a fusion and they see rods and screws and they have such a fear of having rods or screws in their back. But this treatment is really analogous to a cast or a brace. If you break your arm, we put you in a cast, we stabilize the bones. These rods and screws serve as an internal brace or cast to hold those bones in position so that they don't translate and that the nerves are no longer compressed. And typically from a 1 or 2 level fusion, people do not notice much change in their motion or their ability to twist, do normal activities. It's a very effective treatment for spondylolisthesis. And so this is another X-ray of a young lady who I took care of not too long ago who has a slippage of her vertebrae at L4, L5. The bones are no longer lining up. She came in with severe leg pain, a difficult time walking, and she had a large cyst which was emanating from her joint. And this white structure here is a cyst. This is not cancerous. This is a cyst from degeneration, from the joint wearing down, pinching her nerve. So she underwent an operation to remove that and did quite well. In regards to stability, this is a very common problem. It's called an isthmic spondylolisthesis. It's a fancy doctor term for just meaning the bones have slipped out of position. And the reason that has happened is because the pars, or the portion of the bone which holds the segments together, never fused in development. The problem or the result is compression of nerves. So as that disc collapses and slides forward, it pinches the nerve as it exits the spine. So that arrow is showing a normal disc. You can see how high that disc height is, and that circle is the neuroforamen. That's where the nerve exits the spine. If you look at the level below, the disc is collapsed, the bone is shifted forward, and so that neuroforamen is much smaller, and that nerve is pinched, and that will cause severe leg pain. And so this is just an MRI representation of that. I don't know if you guys can see down here this left sagittal MRI, but my arrow is on the L5 nerve root. This is a normal neuroforamen. This is L4 here. And if you see this L5 nerve root, it is severely, severely pinched because of that slippage of the vertebrae. And so this was a before and after picture illustrating the surgical treatment of the patient I took care of. The bone was slipped, compression of the nerve, severe leg pain. So I did an operation, placed a cage in between the bones to open up that space, open up that foramen, take the pressure off the nerve, and then stabilize the bones with rods and screws. And this was a young guy. He was in his 40s. He went back to work. He had complete resolution of his symptoms. So surgery for instability can be very effective treatment for patients. It's kind of like, driving a car with a loose tire. You're not going to be able to go very fast on the highway. And this is a pretty similar analogy to what we see with people who have slipped vertebrae and nerve compression as a result. Surgery, they actually do quite well. So another common thing that I take care of is fractures. I take a lot of trauma call in Atlantic City. And so there's a full gamut of fractures that I see. There are fractures as subtle as the one here. This is a transverse process fracture. Someone, was in a fight, fell on his side, and broke his transverse process, which is this bone here. It is very painful because there's muscular attachment here. But this bone is not important to the stability of the spine. So this will heal without any surgical intervention. You have compression fractures in which there's a depression of the vertebral body. This can happen traumatically. Oftentimes we see it in elderly people, particularly women who become osteoporotic. Their bones get soft and they get compression fractures. This is very, very rarely treated with surgery, typically treated with bracing and physical therapy. If the patient's osteoporotic, their bone health is optimized through medications to prevent further fracture. And then we have fractures which compromise the stability of the spinal column. These are typically higher injuries in which there's a rapid deceleration or a fall. The bone is completely compromised. There is bone fragments which go into the spinal canal, pinching the nerves, and the whole spinal canal itself is not stable. It can shift. And so these require emergent surgical procedures to remove pressure from nerves and to stabilize spinal column. The worst case scenario is a translation of the spinal column, a fracture dislocation, which unfortunately does typically occur, particularly after high-speed mechanism. And in that circumstance, typically there is pretty substantial neurological injuries that we have limited ability to fix. And so these are some examples of some of the patients that I've had to take care of in Atlantic City. And you can see this person on the right, their spine is completely translated. So I had to do an operation to realign that. The problem is we have limited ability to fix nerves when they're damaged, particularly in a traumatic setting. So this person did have some residual weakness in their legs, but did have somewhat of a recovery considering the severity of the injury. This is a burst fracture. So this was a motor vehicle accident. You can see that L3 vertebral body is cracked in half. The bone is now sitting inside of the spinal canal. This person came in with severe pain and weakness in the legs and had to undergo an emergent surgical intervention to remove that pressure. And this is what the surgery looked like. I had to remove the bone, and then I had to stabilize the spinal column with rods and screws, and she ultimately did make a recovery. Our third indication for surgery, or fourth indication, I should say, so we said nerve compression, instability, trauma, so broken bones, deformity. So people that have scoliosis is a very common one, that people develop scoliotic changes over time. You can be born with scoliosis, which is a congenital problem, or you could develop it as you age, as discs degenerate in your back. And the problem with these deformities is it affects the normal alignment of the back. So we have normal curvatures in our spine that keep our head essentially over our butt. And scoliosis affects that. It changes the normal alignment of the spine. And what ultimately happens is we lose the ability to stand upright. So you start to see people falling forward. They can no longer stand upright because they've lost the normal curvatures in their spine. And that makes it very difficult to walk for prolonged periods of time bent over. This is an example of a patient that I had to take care of that had a big scoliotic curve and what's called a flat back deformity. He was able to stand upright because he kind of bent his knees and his hips, retroverted his pelvis so he could stay upright. But after time, he would fatigue and fall forward. And he had a very severe stenosis in his back, a lot of nerve compression. And so he had to have a pretty extensive operation to remove pressure from his nerves, realign the bones in his back. And this is obviously an extreme example of some of the things we do. He needed, this large deformity correction so he could stand upright and walk. Not everybody gets treated this aggressively, and everybody kind of gets an individual tailored approach. The goal is to do as least amount as possible to get people moving. There are some people that do require surgeries of this magnitude, and anytime I undertake a procedure of this magnitude or any procedure, you really have to sit down with people, kind of counsel them on what the recovery process is like and what the expectations for recovery are going to be. And oftentimes, if our goals are aligned and there's a clear understanding of what needs to be done, people do very well. Low back pain is something we all experience as we get older. And I very commonly see people come in with this MRI. So they have degeneration of their disc. So the L4-5 and L5S1 disc is degenerated. It's lost kind of its signal. It's no longer absorbing water. And they have back pain. They have no instability. They have no neurologic compression. They have no deformity, just back pain. These are people who traditionally do poorly with surgery. People that get surgery for this indication, fusions for back pain, are the ones who do not reproducibly get better. And so I very strongly dissuade people for having surgery for pure back pain in the absence of fracture or instability or deformity. Infection is something I commonly have to take care of as well. Most commonly see this in IV drug abusers, but there are people who are immune compromised who do not use IV drugs who have infections in their spine, and it can happen. The disc does not have blood supply, so it is a place that bacteria love to grow. And if you get an infection in your disc, typically it's treated with antibiotics. However, if you develop pus within the spinal canal, that requires surgery. And so this is an example of somebody who had what's called an epidural abscess or pus within the spinal canal. And so I had to do a surgical procedure to remove that pus to prevent them from becoming paralyzed. So that was mostly lumbar spine pathology. I'll briefly touch upon cervical. The principles are pretty similar. If you have a pinched nerve in your neck, it will cause pain, numbness, or weakness in your arm. And those distributions are pretty reproducible. The difference in the cervical spine is that the spinal cord is there. So if you have spinal cord compression, that may affect your function, may affect your balance, your strength, your dexterity. It may not cause pain. We're much more aggressive about treating spinal cord compression surgically to prevent it from getting worse than we are nerve root compression. If you have nerve root compression, we give you a chance to get better with therapy and injections. If you don't, we do an operation. This is a young lady who had extruded disc herniation on the left side. So this is her spinal cord here. This thing right here is the disc herniation. And she had severe pain in her left arm and a C7 distribution. So I did a disc replacement on her. And she was a candidate for a disc replacement surgery because she did not have much arthritis. The purpose of this is to preserve motion in those segments and prevent the likelihood of her breaking down above or below where we did the operation. This is an example of someone who had what's called myelopathy or spinal cord compression. So you can see at the 5-6 level, that disc is collapsed. There's a bird beak in the front, which would indicate that there were bone spurs which developed, and her spinal cord was pinched. So this is the disc herniation, and it is denting her spinal cord. Her spinal cord looks like a kidney bean instead of an oval. And so she had to undergo an emergent operation in which I removed the disc, and then I had to do a fusion for her because of the amount of arthritis that she had. So this is a single level fusion. A single level fusion or even multi-level fusions typically do not affect patients' motion. Motion comes from up here in the upper cervical segments, rotation and flexion extension. So a one-level fusion will not affect motion at all. The concerns with fusions is the development of arthritis above or below where the fusion was done, and that happens in about 20% of people. And so we monitor these folks over time for development of more issues down the line. But these operations are very effective at removing pressure from spinal cord and improving arm pain and weakness. This is an example of stenosis in the neck. So stenosis in the neck will cause myelopathy. The spinal cord here is compressed. So if you look here, this is the spinal cord. Look down here, you can see how much space at the bottom there is for the spinal cord, and you can see here how tight that is. There's white signal within the spinal cord, which is a bad sign. That means that spinal cord is very actively being compressed. This person came in with a lot of clumsiness in her hands. She couldn't button her bra. She felt very unsteady on her feet. Those are classic signs for spinal cord compression. And so she underwent an operation to remove pressure from her spinal cord. And so you can see the before and the after, the difference. Alleviating that spinal cord compression typically allows that spinal cord to heal and for those symptoms to improve over time. Most important, it prevents people from getting worse. So there's a couple different ways that we can do that. One way is called a laminoplasty, where we kind of hinge open the lamina and make space for the spinal cord. So this is kind of intraoperative film showing that laminoplasty where I had to hinge open that vertebrae. And you can see the spinal cord kind of popping underneath here. That opens up the spinal column and removes pressure from the spinal cord. Sometimes people require a fusion. So a laminoplasty is not a fusion procedure. Fusions are required if the alignment of the neck is severe or abnormal. And so this picture on the right shows a x-ray of someone that had to go in the front of their neck, realign the bones with a plate, and then remove pressure and place rods and screws posteriorly. And so there's multiple different ways that we can address these problems. It's really a tailored approach based upon what you need and what is going to provide you the best outcome. Not everyone gets the same approach. There's a lot of factors that go into it: smoking, how much pain you have, how well your bone quality is, how long this has been going on for, and we sit down and tailor the treatment to what is going to give you the best outcome. Quickly, some advances in surgery. Multimodal analgesic protocol is something that we've been worked extensively on. The whole purpose of this is to decrease people's pain after surgery. This is done through minimally invasive operations with disrupt less soft tissue and through anesthesia that decreases reliance on opioids after surgery. Blood loss prevention in surgery. Again, we do minimally invasive operations to preserve blood loss. Very rarely do we have to give autogenous blood transfusions to patients in surgery. We oftentimes can recycle their own blood and prevent them from needing to get transfusions, which can increase infection risk. And again, there's been a lot of advances in minimally invasive surgery. When I was a resident at Pitt, we did a study and we looked at people that received blood transfusions after operations. They had a much higher complication rates after surgery. And so we have made tremendous strides in decreasing patients' blood loss in these operations through various tools. Tranexamic acid is something that we sometimes use that will decrease bleeding. Aquamanus is an intraoperative tool that prevents people from bleeding and coagulates tissues. Cell Saver is when we recycle your own blood. So the blood that you lose in surgery is given back to you. And then minimally invasive surgery. And I can tell you, I do a lot of operations. Very rarely do I have to give somebody a blood transfusion after surgery with implying these type of tools. So gone are the days where we have to do these big operations, big open operations. Occasionally, it's sometimes still required, but a lot of the surgery now is done through minimally invasive measures where we can remove pressure from nerves through very small incisions. We don't have to cut nerves or cut muscles. Patients are up and walking pretty quickly. There's been development of some endoscopic surgical techniques, which also kind of preserve soft tissues and help people to get up quickly. So in summary, indications for surgery: nerve compression, instability, fracture that affects the spinal column, or if they have severe deformity. Back pain in and of itself is typically not a good reason to have surgery. If you come see us at the Rothman Institute, we try to treat patients conservatively initially. Surgery is not cookie cutter. It's tailored to every individual person based upon a myriad of factors, their health status, what their actual complaint is and what the goals are of getting them better. And we're pretty good at taking care of folks and getting them back on their feet. So nothing more humbling than seeing people come in with tremendous fear with back operations and then come back and see me in a couple weeks after surgery and can't believe how good they feel. So thank you. And if there's any questions, happy to take them.
Thanks, Dr. Woods. Okay, Dr. Woods, do you see the questions? We have a couple questions in the chat box.
Let me see if I can. Can you just read them? Because I don't see them.
Yep. Considering COVID-19, are surgeries being done for all patients or only the most severe cases?
There was never a period of time where I stopped operating. I would say definitely April. We were only operating on the most severe cases. So I was taking trauma call, people that were having broken backs, cauda equina syndrome, or people with progressive neurological deficits were getting surgery. All my other patients that typically I would have done operations got postponed. May and June, things started picking up. And now I would say we're pretty much back to normal. Obviously, we're treating people now. If people have high risk factors, so if I have someone that has, compromised pulmonary function and they're at risk if they were to get COVID, then obviously I would try to dissuade those people from surgery. But I've been doing a lot of surgery throughout the summer, and I have not really seen many problems in the hospital. We've been pretty blessed and lucky down here in South Jersey that we haven't been inundated. Our health systems have not been overflowed. Our ICUs have not really been at capacity, and I have not really seen an issue with anyone having surgery, and we're pretty much back to normal. And I have also operated on several people that were COVID positive. Most of them were trauma cases. There was some literature or some concern that patients who had COVID did poorly after surgery. They had prolonged intubations, increased pulmonary complications. And I have not necessarily seen that in the patients that I've taken care of. So, we're pretty much back to normal now. Patients, there's things that are abnormal. You come to the office, you got to wear a mask. So, you can't touch. I typically touch and hug my patients. So you know, that's kind of changed a little bit. And so we got to take the necessary precautions. You got to get COVID tested before surgery. But aside from those inconveniences, we still kind of been able to take care of people, particularly now. It's pretty much back to normal.
Okay. Are you fellowship trained? Do you work with a neurosurgeon?
You know, that's a very common question that people ask, because there's some, you know, there's some confusion even amongst doctors what differentiates a neurosurgeon and an orthopedic surgeon. So, you know, I'm an orthopedic surgeon. I was trained as an orthopedic surgeon. So you do an orthopedic surgery residency, you do all orthopedic subspecialties. So you do joint replacement, you do fracture work, you do sports medicine, and you do spinal surgery. Then after completing my orthopedic surgery residency, I did a specialized fellowship in spinal surgery, where the only thing I did was spine operation. And so now, yes, I'm fellowship trained and I only do spine. So my only specialty is spinal surgery. I don't do any facets of orthopedics anymore except for spinal surgery. Neurosurgery is the same. They do a residency. The only difference between neurosurgery and orthopedics is that in addition to spine, they learn brain stuff. So they do, you know, intracranial stuff in their residencies. But most people now who are practicing either orthopedics or neurosurgery and do spinal surgery have to be fellowship trained, and that's all they do is operations on the spine. So when I did my fellowship, I was fellowship trained with neurosurgeons and orthopedic surgeons. And ultimately, you want a spinal surgeon to be the person taking care of you, someone who's dedicated to doing only spinal operations and taking care of spine patients, and that's what I do.
Okay. What's your best guess for burning, aching, throbbing behind the kneecap?
I mean, that's a pretty generalized thing. Behind the kneecap is probably prepatellar bursitis. You know, if you have a pinched nerve in your back, it will radiate down the distribution of the nerve. So that's going to be down your leg. It won't be focal to your kneecap. So my best guess would be that would probably be prepatellar bursitis or patellofemoral arthritis within the knee joint itself. And, you know, something like that typically is treated with an injection initially to determine if that's the area of pain. It's coming from your patellofemoral joint.
Okay. How do you determine that a problem results from an arthritic knee, bone on bone, versus disc issues in the lower back?
So if someone has an arthritic knee, they'll have pain focal to their knee. It doesn't radiate, and it's activity related. So they get up, they walk, they have pain in their knee. And an easy way to determine if it's coming from the knee itself is you get an injection in your knee. If the injection in the knee transiently improves symptoms, you know it's coming from the knee. Now, you can have referred pain from your back that goes to your knee. Typically, it won't just be in your knee. It will shoot down your leg, past your knee into your shin. And again, you know, we get an MRI. We look to see if the nerve is pinched. The nerve that supplies that area is typically the L4 nerve root. So that's the nerve we would look to see if it was compressed. But, you know, when you're working up someone with knee arthritis versus back problems, typically the first thing you do is, based upon what their symptoms are, if it's isolated to the knee, you do a knee injection to see if that helps.
Okay, that's all the questions in the chat box. Does anybody else have any additional questions? If you'd like, you can unmute yourself and ask it out loud. I'm sorry, I think someone's trying to ask a question. I can't hear you. You can always email me directly as well. I sent out the link for the presentation, so you can email me your question directly, and then I will work with Dr. Woods on getting the answer for you. Okay, so as previously mentioned, Dr. Woods sees patients that are Egg Harbor Township and Washington Township locations. I'll send out a link tomorrow with, again, the recording of the presentation, along with the contact information for Dr. Woods or Rothman contact info in general, in case you have any other additional questions. But again, I just wanted to thank everybody for joining us today. I hope everybody continues to stay safe. And again, I'll be sending out that link tomorrow.
Thanks, everybody. Be safe.
Thanks, Dr. Woods.
Bye-bye.
Right.